Welcome, everyone. Very excited to be here with you today at the 157th episode of the 988 Crisis Jam, where Mary Sowers will be talking with us as our featured presenter about bridging intellectual and developmental disabilities, or IDD, and mental health systems. And I am Dr. Aisha Delaney-Brumsey. I am the Chief Strategic Growth Officer at Fountain House. Next slide. You're here today, so you all may have this, but it's always a good reminder, talk.crisis.now is where you can go to register for the jam, which you need to do before joining. You can also get registered for the newsletter and get all of the different materials that have been utilized throughout previous jams, as well as see previous last week's video or get links to other videos. It's a fantastic resource. I use it all the time. I send it to colleagues all the time. Just a wealth of information. And this slide, one of my favorite slides, actually, just a reminder about the fact that we have had over 150 episodes, more than 400 unique speakers at this point. And it just popped up in the chat. But if you have a idea about a topic or a particular speaker, use that link below to make a suggestion on who else should be added to this really illustrious list of people who have significant contributions or have made significant contributions to improving our crisis. So getting into the news, these articles are on the talk.crisis.now website, and they're also going to be linked in the chat. But the very first piece of news is from the Savannah Business Journal, saying here, Giving Kitchen, Georgia Restaurant Association, and BBHDD launches hashtag 86 the Stigma campaign. If I'm remembering my Georgia correctly, someone in the chat will correct me, that's the Department of Behavioral Health and Developmental Disabilities. So started a campaign focused on really raising awareness about 988 amongst restaurant workers, with the recognition that restaurant workers have significant needs. And one of the stats that was even cited in this article was the fact that people who work in the restaurant industry have the second highest rate of overdoses compared to other industries. The first highest was construction. So just a news article highlighting another unique way of getting the word out about 988 to people who might need it. Next slide. This article here is about some of the changes at Vibrant Emotional Health and 988. And I actually believe that I might have Dr. Tia Dole here with us from Vibrant.
Yes, I am here. I am here.
Perfect. Turning it to you.
Okay, so because I know FP folks are really keen on jumping into the conversation today, but I did want folks to know about some changes. So thanks for inviting me to come and speak about some of the changes that we are making. And I'll say, 988, the number, right, the 3-digit number, launched a year and a half ago. And now we actually have been engaging in UX and A/B testing, and what comes out of that are some feedback that we've heard from folks on the line. So I'll just go through this really quickly. Y'all can read it, but we updated our waiting music. People, to quote my children, low-key hated it. And so we updated the music to be calming and also uplifting. You don't want things to be super incongruent with what your emotional experience is. So we've updated to more piano music. The IVR is a little bit shorter. One of the things in thinking about press 1 for this, press 2 for that, it can feel like protracted if you're listening to the message and listening for your own and especially if you want to go beyond that. We've also hired new talent to do the IVR message. People didn't really like the voice from before, and they felt like it didn't sound like a real human being. And so we've incorporated folks who sound like people and don't sound like robots. Now, the next thing here is that we have the option to skip IVR. Now, if you press 0, you can skip IVR and go directly to a counselor. But we want everybody to know that that feature exists. It has existed, but most of the time people didn't know about it. And so if you don't want to go through a whole message, please advise people you can just skip, can press 0, you can skip it. And the last thing is that while folks are waiting, they're receiving information about other services. And I'll just say, we don't want folks waiting. So, you know, this is like a good and bad, right? We don't want folks waiting on the line. We really want people to have their calls answered within 30 seconds, which there mostly are. But we want to ensure that people have additional information while they're waiting. And essentially what we're trying to do is have people stay on the line. We don't want the abandon rates to go up. And, you know, my hope is with each iteration, things will actually feel a little bit more, feel better to the folks reaching out to us. So that was my update. I appreciate y'all setting aside time for us to share.
Thank you, Dr. Dole. It's amazing to hear about all the changes you're making. You're getting some props in the chat as well. And so this is a great quote from Dr. John Franklin Sierra, who's involved in the LA, consumer mills in the LA crisis system. And I love this. The full scope is overwhelming. Help others see the baby steps. So think about taking a huge problem and breaking it down into bite-sized, manageable chunks. It's the only way you eat the proverbial elephant or shift a crisis system. So thanks for that quote. Fantastic. Next slide. One of my favorite parts of the Crisis Jam got Crisis Trivia Hot Seat. Larry Villano, I hope I said your last name correctly, President and Chief Energy Officer of Resilient Health. Welcome.
Thank you. Good to be here. I'm a little nervous.
I mean, you should be nervous. You are on a full game show right now, but you got this. We're going to get you through. So on February 16th, 1968, a red phone rang in the police station, but that first 911 call didn't include geolocation. Early wireless integration was a challenge with difficulty triangulating location relative to nearby cell towers. So the question is, a tragedy in blank year led to changes with the FCC requiring wireless carriers to pinpoint precise locations. So you have options here. You can guess the year. I mean, you could know the year, so you could just tell us the answer. You could wait to see what the audience says and go with the wisdom of the crowd. You could phone a friend if you see a friend in the audience who you want to ask. So what would you like to do? How would you like to proceed?
You know, I think I'd like to phone a friend, okay. John Draper.
Ooh, John Draper, are you here? Can you help your friend out?
John, help me.
I am here, and I'm actually eating a peanut butter sandwich right now. My mother told me never to talk with my mouth closed, open.
I'm in a crisis, John, help.
Well, I'm only thinking in terms of wireless carriers, right? So one would think that wireless carriers started to kind of take hold in 2006. By 2014, they were ubiquitous. So I would probably say 2006, but let me be clear, I don't know, Larry.
All right, Larry, you going with John? Are you going with the crowd? The crowd is really split. 2006, yeah. 1999. None of us really remember when we got our first cell phone, I guess. Like, so what are you thinking?
Yeah, let's go. I'm feeling 2006.
All right, 2006 is the answer. Let's see how you did. Okay, 2014. So sorry, you didn't quite win, but you always win when you participate. You get a shirt. You were up here. Good job. But, you know, unfortunately, a tragedy in 2014 led to changes with the FCC requiring wireless carriers to pinpoint precise location. And you can see here, the speed of response really matters. The 911 call in suburban Atlanta went to another county, and the dispatchers were unable to determine the woman's location, who was trapped in a car. So that, even though 2014 seems actually significantly more recent than I thought, I got this question wrong when I was asked during the prep. So Thank you so much, Larry, for your participation.
Do I
And-
get the t-shirt, Aisha? 'Cause-
Oh, you get the participation just for participating because,
Oh, good.
of course, and that is true for anyone who would like to be on the trivia hot seat. Should you want to participate, you get a t-shirt. Thank you so much, Larry.
My pleasure. Thanks. It's great to be here.
Next slide. Great. So now I'm really pleased to call up Miss Mary Sowers from NASDDDS, who is the executive director there, to talk to us about bridging IDD and mental health systems. I will turn it to you, Mary.
Great. Thank you so much, Aisha, and thank you everyone for having us today. It's my great honor and privilege to be talking about the Link Center. And I want to start by saying we've got the tagline of bridging IDD and mental health systems, but really since the inception of the project, we've come to realize that individuals with all types of cognitive or communication differences really benefit with some of the bridging work that the Link Center aims to do. So just a quick footnote that we will be really expanding that scope, and you'll hear us talk about, of course, supporting individuals with IDD who have co-occurring mental health and substance use issues, but we're also really hoping to be inclusive of individuals with brain injury, other cognitive disabilities, or other communication differences as well. Importantly, the Link Center is a project of national significance funded by the Administration for Community Living, and so it's with a great deal of gratitude to ACL and other federal partners that you'll hear about in a bit, that we're able to really be here standing this important technical assistance and resource center up. So next slide, please. So as many of you probably know, unfortunately firsthand, our nation really struggles to provide community mental health supports for individuals with IDD, brain injury, or other cognitive disabilities. And there are many reasons and contributing factors to why that continues to be the case today. But that said, our systems of support are really stretched by striving to support individuals who are presenting with complex needs. And so Aisha mentioned that I'm from the National Association of State DD Directors, or NASDDDS, and our members, along with mental health commissioners across the country and law enforcement and others, are really wrestling with how to bridge the gaps between the service delivery systems to really support people in a holistic way that meets their needs and doesn't sort of presume that because someone presents with an intellectual or developmental disability or brain injury, that that's a monolith in that individual's life. We know that many states are really striving to meet the obligations that have come about by litigation and making sure that they've got system improvements in place. But we've also come to realize that we're a bit behind in really heading off these issues. And so we're trying to build capacity both for an acute situation that is presenting in many states, but also for the longer range, so that we've got a continuum of care that really supports individuals throughout their communities. We also recognize that a lot of the anachronisms that have led to the lack of support for individuals with IDD and mental health supports have also contributed to a lack of capacity building or expertise in these areas. And so the Link Center is also aiming very much to try to address the capacity dearths across the country in these pieces. And unfortunately, we know too that many state systems and our federal systems have really built around silos of support for individuals. And these silos have really contributed to fractured approaches to supports for individuals. And also, certainly many of you on the line are familiar with the really terrible things that can happen when our first responders and our medical providers don't have the tools in their toolbox necessary to support individuals who have cognitive or developmental disabilities, brain injury, or who have communication differences. So next slide. So one thing I want to really spotlight here today, and you'll hear from my partners in just a bit, but my organization, NASDDDS, is partnered in lockstep with the National Association of State Mental Health Program Directors and NADD, the National Association for Dual Diagnosis, in the operation of the Link Center. And we recognize that it's an increasingly necessary partnership, not just to model across our associations at the federal level, but for our members to respectively join forces at the state level to really make meaningful change around individuals and their support needs. And so we also have partnered with some additional organizations as well, notably the National Association of State Head Injury Administrators, who are a key partner on some of our elements that we'll talk about in just a bit. But we have a strong history across our 3 associations, really starting and stemming from SAMHSA convening in 2018 that really launched what I think is going to be just now a lasting partnership for many years to come. Next slide, please. So the Link Center partner organizations, I love this slide because I think it really embodies what's necessary to have a real person-centered approach to supporting individuals with IDD, cognitive disabilities, brain injury, and mental health concerns. So as you note at the top, we've got our 3 primary organizations indicated, but we've got a great bevy of other partners who really round out the expertise that's necessary to stand up the Link Center. Importantly, we've got a lens of individuals with lived experience really helping us shape our work with Green Mountain Self-Advocates and the Autistic Self-Advocacy Network and Communication First. And as I mentioned, the National Association of State Head Injury Administrators is also a core partner and helps lead many elements of the work as well. And then we've got our research partners who bring not only a lens of evaluation and research and how we can continually improve the project, but frankly, a lot of direct experience in this space themselves, and also with an eye toward really ensuring that the experiences of individuals with that we're trying to support through the Link Center are representative of all individuals. So we've got a lens of equity and inclusion and diversity in all the work that we're doing as a part of this effort. Next slide, please. So the key goals of the Link Center are a little deceptively simple. We are really hoping to spur systems change, improvement in policies, service design, and service coordination for individuals with disabilities who also experience mental health conditions. We're really aiming to improve both the clinical capacity to support individuals with different communication styles, but also the direct support professional workforce skills in this area. We know that for individuals with developmental and developmental disabilities, intellectual disabilities, and brain injury and others, that it's so important to have not just a clinical intervention, but that there are robust supports that in their day-to-day lives that help them. And so we all know how important the direct support professional workforce is in filling that role for everybody. And it's especially true for individuals who've experienced mental health crisis and need those ongoing supports. And then at its very root, the Link Center really hopes to improve access to person-centered, culturally and linguistically appropriate mental health services and supports. And again, while that's easy to say, we know that we've got an uphill battle to make sure that it's ubiquitously available across the country. Next slide, please. So the Link Center's key activities, you'll see on the left-hand side that we're trying to stay rooted in with an equity lens and a continuous quality improvement lens, because we also know that this project, as monumental as it is, can continue to learn as we go. And so we want to be as nimble as possible as we're standing up the bones of the effort. And in that vein, we have our partners at the Ohio State University Nysonger Center. Quick shout out to them for really designing an evaluation process that helps us learn with every single step that we take, which has been a beautiful addition to the work that we're doing. We've got, importantly, and probably should be blown up on this slide, there's a steering committee comprised exclusively of individuals who identifies having a lived experience of IDD, brain injury, developmental disability, communication differences, neurodiversity, and having experienced a mental health condition. And that steering committee is currently comprised of 12 individuals. We will be doing some targeted recruitment to augment that a bit, but it has really helped shape some of the early priorities of the Link Center. And I should mention that we're about 15 months in to the Link Center getting off the ground, and we're still in a building mode. It feels like we've got some of the really important scaffolding up, but we've got a lot of work yet to do to really breathe life into the resources and connections that we hope that the Link Center can facilitate over time. We also have shared learning groups, and these are quarterly meetings really aimed at, as the name implies, a shared learning experience for all who attend. My colleague, Dr. Stacy Nonamaker, who's on the line right now, is going to drop into the chat a link to the shared learning groups registration information. Importantly, the shared learning groups are aimed at specific groups. So we've got one aimed at individuals with disabilities, individuals with lived experiences, family members, direct support professionals and clinical professionals. And so the groups have a common theme. We actually have some coming up next week, really aimed around the topic of trauma. And the content across the 4 groups is comparable with some tailoring so that it's really relevant to the groups and the audiences who we're aiming for in those groups. We're building a robust resource library that will be housed on a website. We're working with our partners at ACL now and hope to have that available soon. And at the end of the day, we really hope to create an environment where we've got open sharing, learning, and that we're really trying to move the needle on those goals that I discussed in the prior slide. So next slide, please. So some of our outputs, and these will be very tangible, and hopefully we'll be able to come back in not too many months and share that we've got that curated resource library available and at your disposal. And that will be a continually living library. And so given the breadth of the expertise of the individuals on this call, we'd very much like an open opportunity to get your best thinking on things that we should have in this space. We'll have a website that will really serve as a hub. We're trying to identify best practices and how to scale some of those across the country, both in terms of state systems, but also clinical and direct support strategies that individuals can use in their day-to-day lives. And then importantly, really thinking about how to ensure that the direct support workforce has the competencies they need to be successful in trauma-informed supports, and really making sure that we've got different tools in the toolbox available for the various audiences that we hope to reach with the Link Center. Next slide, please. So as I mentioned earlier, the steering committee really turns out to be the rudder of the work of the Link Center. We had an overwhelming response to our recruitment. We had over 100 applications of individuals from across the country. And so we really leaned in heavily to make sure that we had a strong and diverse steering committee, really representative of folks from different geographic areas across the country, race, ethnicity, culture, age, communication strategy, and disability type. We meet quarterly with the steering committee, but if you're able to tune into some of the shared learning groups next week, you'll see that our steering committee winds up being very active partners in the development of the topical areas that we're hoping to really cultivate resources around. And so the steering committee's also really helped us dive into, and this is an ongoing conversation, but language use, engaging families and persons with lived experience, and priority areas for resource identification and development. And just a moment to pause on the notion of language. We know that some of the challenges that our systems have experienced are really due to different vernacular. And so sometimes we are saying the same things with different meanings, and that has sometimes impeded progress in really making sure that there's a holistic and person-centered approach. And we're recognizing too that language is power. And so we're really trying to use language that really sets the stage and the expectation that individuals regardless of their disability, can benefit from and really thrive when they have the right clinical supports that recognize the complexity of their mental health conditions, but also the ongoing supports that they need to be successful longer term. So we're continuing to parse through that language issue. And it won't surprise many of you on the line as well to know that balancing the individual in the context of their family is such an important balancing act, so that we're not sort of inadvertently usurping the authority or autonomy of the individuals that we're aiming to support. And so the steering committee has been quite wonderful in helping us parse through that work as well. Next slide, please. So one thing, and while this slide seems so simple in its title, we are extraordinarily grateful to the folks at SAMHSA for leaning in partnership in a way that I have not seen in my multi-decade, that I won't go into lengthwise for revealing my age, but career. This is really quite a historic moment in time in terms of the partnerships that are emerging at the federal level to really dive deeply on supporting individuals with IDD, developmental disabilities, brain injury, different communication strategies, and mental health conditions. It is really amazing, and we're super grateful to SAMHSA for really joining in lockstep with ACL in this effort. And so we'll talk a little bit about the efforts that we've got underway with the Link Center and SAMHSA. Next slide, please. So obviously the notion of 988 and Suicide and Crisis Lifeline is important for all of us. it is equally important to individuals regardless of their disability status. And yet we know that sometimes individuals who might communicate differently or who might need more time to understand what's happening, some may not always get the on-demand engagement that they need. And so we want to make sure that as 988 is taking root all over this country, that we've got an eye towards inclusivity so that individuals, regardless of how they might communicate or present, whatever disability they might have an equal opportunity to get crisis supports when they need it. We know that individuals with disabilities experience mental health at a higher incidence even than the general public. We know that there are lots of steps along their lifeline that may have contributed to trauma. And so we need to really build an inclusive system of supports. And frankly, it's our firm belief that if we can support all individuals, it's really greater for the general public as well. And so we've got an eye toward really helping to raise all boats with this effort. Next slide. To that end, SAMHSA has funded with ACL the opportunity for a policy academy. And this is aimed specifically at states, territories, and tribes who really want to do some deep end work at building collaborative systems across the various silos that exist within the state. And so we are bringing 5 or 6 states together with a required composition of IDD, mental health, Medicaid, 988 Lifeline, child welfare, and others to come around the table and really discuss how they can build an inclusive approach to 988 and crisis response systems. We recognize that not everyone can be expert in all of the aspects of disability, but we do think that there's great opportunity to forge relationships and build systems that are responsive to one another in a way that can really make the 988 system as inclusive as possible. And to that end, the Policy Academy will include a survey of really to try to understand the very specific state ecosystem. We'll also engage with stakeholders and partners at the state level to understand how it's playing out in the across the state on the ground, recognizing that even at the state level, it might not be a monolith, and really developing some state tailored interventions. The Policy Academy will include virtual learning opportunities and will culminate in an in-person academy with a work plan that the Policy Academy will follow along and provide ongoing TA in the following year. We're super excited. This week is pivotal. Applications are due from states, tribes, or territories by Friday, and we've had wonderful responses from states. So we're really anxiously awaiting the submissions and hope to come back in just a few months and let you know who our partners at the state levels are who are engaging in this first foray around this important Policy Academy. So many thanks to ACL and SAMHSA for their support of this work. Next slide, please. So in thinking about how to present the information, probably should lead with some of the access challenges that have really spurred the interest and commitment to the Link Center along the way. You can go to the next slide. But one of the things that we are really trying to combat with the Link Center are those historical perceptions of individuals' ability to benefit from mental health treatment. Some of you may be familiar with the fact that for many years at the federal policy level, there was a presumption that individuals with IDD couldn't benefit from restorative or rehabilitative services. And because that winds up being the predominant way that most states deliver Medicaid mental health services, clinical mental health services were out of reach for many individuals with intellectual or developmental disabilities. And there continues to be a presumption that individuals with IDD can't experience mental health conditions at all. In fact, you might live in a state that still says if you have a primary diagnosis of IDD, then you can't really access the mental health system. And while these anachronisms persist, they're really based on old and outdated information, because we know that individuals with intellectual and developmental disabilities, brain injury, and other cognitive disabilities can experience mental health conditions to the same degree as anyone who doesn't have those other conditions. And frankly, that we have a broader recognition that individuals aren't monolithic. And so these sort of artificial division lines have really stymied access to important supports for individuals over these many years. And we really hope to turn the tide on that. And I can't emphasize enough that I think that the federal partners that are coming to the table around this issue offer the greatest promise, frankly, in history to really overcome some of those challenges. And what this really spotlights is that it's important for the systems to work together. An IDD system can't do it alone. A mental health system can't do it alone. A child welfare system can't do it alone. And the 988 system can't do it alone. But together, there are many strengths that can be brought to the table to really leverage the power of all of those different systems to really wrap around an individual and provide a truly, truly, truly person-centered approach to supports. But we also know that we've also got a workforce challenge in our country. In home and community-based services, workforce remains the paramount challenge amongst really giving individuals access to supports and services. And this is exacerbated for individuals who might also have a co-occurring mental health condition and may require some additional supports. And so we've got work to do in the direct support professional workforce area, but we also have a lot of work to do in the clinical arena. We know that because of some of the anachronisms that I discussed a moment ago, financing strategies have been built around those presumptions, and oftentimes that has contributed to a lack of clinical expertise development in these areas. And we really are hoping that with this tide turning, that we've got an opportunity to help clinicians really understand how they can, without compromising an evidence basis, really work with individuals through adaptations and accommodations, allowing for additional time and really making an impact on those treatment areas. And then, of course, we know that our systems writ large have to have a continuous eye toward equity and accessibility to make sure that as we are thinking about the all, we are truly inclusive of everyone, including underserved and marginalized communities or individuals who communicate differently and may not have access to technology readily. So we've got a lot of these issues have contributed to the access issues we're trying to combat today. So, but again, not to be Pollyanna-ish or naive, but I think we have this critical moment in time, and we hope to very much seize on the commitment of our federal partners and our state partners in really wrapping around these issues in a meaningful way. So, next slide, please. So any questions, happy to take those. We will have a website soon. And in the meantime, there's on the next slide, there is a mailbox if you'd like to get in touch with us. I've got lots of our partners on. I can't emphasize enough. Our partnership with NASDDDS and NAD and NASHIA and the other groups I mentioned is just critical. But NASDDDS and NAD really help us operate the Link Center. And so this is a joint, very, very, very much a joint effort. So thank you so much for the opportunity to talk with all of you today. It's quite an honor.
Thank you so much for the presentation. You're getting a lot of positive feedback in the chat, and people reflecting on their experiences with family members with IDD or people they're working with, or their own experience, and how this really, they're really hopeful about the work that the Link Center will be doing. So thank you so much. And so just very briefly, I'm going to call up two discussants. I'll start with Wendy Morris from NASDDDS. Wendy, do you have just a minute or so of reflection on what you just heard?
Yeah, so I just want to, emphasize as well, this work is just so terribly important. We know that people who have mental health challenges that also have a disability or communication differences just simply have different experiences. Like you said, there were some comments in the chat about people being hung up on. We've heard that from our steering committee as well, especially when people use assistive devices. But we also know folks with complex needs are boarding in the emergency rooms. They have long wait lists for services. They're more likely to, engage or interface with law enforcement. And so these partnerships are so important, not just between mental health and IDD, but also, with aging and independent living, Medicaid, child welfare, the justice system, workforce development, and so on. And really, like Mary said, being able to partner with ACL and SAMHSA, these federal partners, so critical to really moving the needle. So, so great to have the time on this today. Thank you.
Thank you so much, Wendy. And now I'll call up Jeannie and Far, but NAD, you hear Jeannie?
Yes, thank you so much. In addition to the wonderful comments that Wendy made, I'd just like to reinforce again the importance of partnership. Everything we do and the best of what we do comes out of these partnerships. And when we think about how individuals with intellectual and developmental disabilities don't have access to effective mental health treatment in most places around the country, I think it just reinforces the importance of this incredible work that we're doing together and the incredible partnership that we have, that Mary talked about, and that expands and continues to bloom. Let me say, while I have all of you here, if any of you know of an outstanding resource that that you think that we should consider, would you please email it? It could be an article, a book, a webinar, a training, anything at all that speaks to how we can more effectively work with, interact with, provide support to individuals with the dual diagnosis. We would very much appreciate it. And we're amassing these resources in all the key areas that we think about in our work. And I know I don't have time to go over them, but just anything that you think is important, anything that's important to your work, please email us so that we may check it out.
That is great. Thank you so much for those reflections. I know the theme around the importance of partnerships to really bridge the gaps that people fall through when they're in between systems or being supported by different systems is one that we come up against all the time in this room, in this conversation. And thank you for the reminder about folks on the call sending in potential resources. The link to that email is in the chat. Really appreciate that presentation. It seems just from I can tell from just the chat, really touched a nerve with, in a good way, with a lot of people in this room. So thank you so much, everyone. Moving along, next slide. So we'll be calling up now. We've gotten to our crisis talk, and Stephanie Hepburn will be here with Maddie Stoltz, focusing on a theme that we've also been trying to focus on more and more in the Crisis Jam around youth and mental health and crisis. So Stephanie, I'll turn it to you to close.
Thank you. So I'm bringing on Madeline Stoltz, and she was among the 3 million plus US high school seniors in 2020. Maddie, thank you so much for joining us. I know you have a busy college schedule, so we're really grateful that you're able to join us. Can you share with us how the pandemic complicated your mental health, but also how it altered your trajectory?
Yeah, definitely. So I was super fortunate to talk with you, of course, on all of these subjects, but I especially started noticing that getting kind of just ripped away from the school routine and friendships and connections that I had with no warning really was such a shock to my routine, to my sleep schedule, all of these sort of physical aspects and also mental aspects of being isolated. And I had already started going to therapy and dealing with some existing depression and anxiety. But again, this really just ripping away of routine, but also of, my graduation, my prom, all of these milestones. It was very shocking. And that kind of shock to your system can really increase the same symptoms that I was feeling of depression and anxiety. And luckily, I could have gone one of two ways, but luckily I, started realizing that I wanted to start my major in psychology as quickly as possible. And since I wasn't able to start college until the next year, I started volunteering with my local branch of NAMI, my local affiliate in Tallahassee. And it was the best thing I could have done for myself. I started hearing similar stories that were so, parallel to mine from people my age, a little older than my age. And, the old adage is very true that, helping other people can help yourself so much. And so that was extremely instrumental. And in terms of altering my trajectory, it changed my whole life. I ended up getting super involved in mental health advocacy, which cannot be said for all psychology majors. That's not, part of a curriculum. You have to sort of learn advocacy for yourself. And so once I got more and more involved in NAMI, I realized, this is what I wanted to do for my career. And as as we spoke about, it is so important to have that moment of, your major or your, classes turning into your passion and what you want to do with your life, especially in mental health because of these workforce shortages that we're having. And, it's been so inspiring to be able to come from such a dark place in 2020 and that quarantine time, now coming out of that into a place where I feel like I am starting to become a part of this new generation of advocates and workforce, which is fantastic.
We spoke a little bit, I think we probably have maybe one more minute, but we spoke a little bit about having youth participate, why it's important for the young person, of course, but also, as you mentioned, for the workforce. Can you give a couple of examples or one example where you felt people were well-intentioned, but just didn't have that exposure?
Yeah. So, the example that I typically give is a lot of, older folks, they do not have the same sort of exposure or community of LGBTQ individuals or even, BIPOC individuals. A lot of people grow up in this sort of homogenous environment that everyone looks like them, talks like them, acts like them. And so, dealing with individuals like that, it's hard because you want so badly to be able to show them, that diversity is important and that is the way that the world is turning, and so it has been a slow process of trying to increase that sort of awareness and literacy, but I think that the more young people that are involved, the more exposure we can bring to people like that, and hopefully get everyone on the same page.
Thank you so much for joining me, Maddie. I'll send it back to you.
Thank you. Thanks so much.
Yes, thank you to you both, and just want to echo the thanks in the comments for Maddie, for you sharing your story, and of course Stephanie for gathering all the amazing stories that help inform this work. So thank you both. Next up, we've got Dr. John Palmier from SAMHSA to give the SAMHSA update. John, welcome.
Thank you. Good to be here. Thank you, Maddie, for sharing your experience and insights, and also just want to provide a shout out for Mary from the Link Center and the tremendous partners that they are in helping us put together a plan for Policy Academy, different trainings, and really focusing on the needs of people with intellectual developmental disabilities and co-occurring mental health conditions. It's been a tremendous partnership and really excited about the work moving forward. So just a couple of quick updates. One, that I wanted to let people know about. Obviously, we're continuing to expand work within our Crisis Training and Technical Assistance Center. I think we've talked quite a bit about that in recent weeks, but did want to alert everybody to an upcoming webinar that really is intended to kick off a whole portfolio, a whole kind of schedule of work focused on equity. So this webinar will be scheduled for January 31st, 1 o'clock Eastern time. I will put the link in the chat, but really intended to kind of set up some foundational understanding of key terms to inform vision planning, action steps toward creating and embedding equity within the crisis system. So very much looking forward to that conversation and building upon that conversation to actually move with actionable steps to really improve equity within the crisis system. I also did want to flag that our 988 Partner Toolkit now is searchable, where we've mentioned that we're always making improvements to the Partner Toolkit, but now you can actually search and filter all 988 materials by audience, population, language, resource type, really intended to make it much easier for people to find the best materials for themselves and for the communities that they're working with and the audiences that they're trying to reach. And then I also want to let folks know about the SAMHSA Prevention Day, which is January 29th at the National Harbor. That event is free, although it does require registration, and there will be sessions on 988 crisis services and suicide prevention. And then lastly, I'm just going to briefly hand it off to our 988 Technology Lead, Stephanie Grosser. Dr. Teodol did mention some improvements to IVR, really in the spirit of always looking for ways to improve the experience of the help seeker. And Stephanie's just going to speak very briefly to a couple of other improvements that we have made to the system.
Thanks, John. I'm happy to be here today. So one improvement besides the IVR I wanted to talk about was our pre-chat entry experience. So last year, and since we launched chat for 988, you had to fill out a lot of required questions in order to access a counselor via the chat mechanism. Chat was our lowest modality of people contacting 988. And we looked into comparing what's required to access a counselor by phone versus text versus chat. And we saw there was a lot more requirements for the user to get through to a counselor on chat than the other two modalities, text and phone. And so as of December, we removed the requirement to answer many of those questions, and we only left 3 as required. 2 are for the purposes of seeing how urgent someone needs to talk to someone for triaging purposes. And the last one we left as required is your zip code, because that's how we route chats to the local crisis center in your state. Whereas by text and phone, we use your area code. And so to access a crisis counselor today on chat, you answer those 3 required questions. The rest are optional, and then you can access a counselor. We are excited to do additional user research, and we have been doing some on the overall pre-chat experience, but I wanted to just touch on that one since that did launch back in December.
Great, thank you, Stephanie, and thank you so much, John, as well, for that update. Great to hear about some of the changes that are happening. Next up from NASDDDS, I have Dr. Deb Peinel. Deb, are you here?
I am. Hello, everybody. Nice to see you. All right, so I'm going to just try and, first of all, give a big shout out to the concept of partnerships and talk a little bit about the papers that we've been fortunate enough to write through NASDDDS on behalf of SAMHSA. And I show here just a whole bunch of resources that are available to you for free. You can download them. These slides will be available. You can just Google some of these. The Connected and Strong one is still in review, but the other ones are available, and the Connected and Strong one will be available soon. And really, the theme of working with complex populations in the crisis space has been something that NASDDDS has been talking about for quite a while through these various papers and in other venues. So what I want to talk a little bit about is what the Link Center is going to be working on with the shared learning groups. And I have the great good fortune of partnering with NASDDDS on that as well. I want to talk about trauma and complex populations and just give a teeny snippet of stories that came across my desk. If we could just go to the next slide. You know, I serve in multiple roles, but these are some stories that came across my desk not too long ago and could come across anybody's desk on any day. One was when, in my role as the state medical director in Michigan, I got a call from a mother who was very distressed. Her deaf son was in a mental health and substance use crisis, and she had asked for him to be brought for help, but was afraid that if the police came, they wouldn't use the proper protocol with a deaf interpreter. And we actually had to navigate through our deaf services and the courts and a bunch of different agencies to help work with this mom to help her son get the help that he needed. Another time, we heard a story recently about a person who required a communication device, who was in a suicide crisis, and the device had to be removed, or was removed, didn't have to be removed, let me restate that, was removed due to concerns that it was a safety hazard. And that really distressed this individual for obvious reasons. We have to think about that. Another story was a youth who was involved in juvenile court clinic that who had a stuffed animal for support, and the stuffed animal was removed from that youth. And then another person who became aggressive and was seen as, quote, arrestable but the people didn't realize that this person really couldn't articulate clearly that they had recently lost a caregiver and had a new caregiver and didn't know how to communicate. So these are stories that we hear all the time about complex populations who might be in distress, might be in crisis, but might have different ways of communicating, different things that happen. And this can create its own trauma for individuals. Next slide. So I want to remind people in the crisis space about the importance of trauma reduction strategies. We talk about trauma-informed care in a global sense, but it's really important that as we think about handoffs and communications, whether it's family members calling someone for crisis help or someone calling themselves for crisis help, really, or us as crisis providers trying to hand off to the next provider or the next system or the next caretaker, that really the communication about what's going on with this person is really important. Helping people feel oriented to the intervention that is about to happen or what's happening, giving people information we know a lot about. Providing information gives people a sense of control and autonomy, and respecting their autonomy, giving people information about options, really thinking about how best do people communicate, whether it's through words, through pictures, through ASL, whatever the communication might be, through technological devices, and then including support networks, family, friends, direct support professionals as appropriate and available to help improve those communications in crisis moments is really, really important to reduce the likelihood of an escalation and a tragic outcome. Next slide. Just a couple things we've written about and will be writing more about in these future papers are things like, again, using person-centered approaches to consider the needs of people with complex presentations, and the use of tools and frameworks. Dr. Chuck Browning and Dr. Coates and I and others wrote in the medical paper from this year that will be out soon about the ADET model, which is a commonly known model in nursing. And I just want to give a little brief pause, shout out to my Michigan team, who we were just talking about these things this morning about developing some of these models in crisis stabilization centers. But the ADET model, which is really about acknowledging the person by name, introducing yourself and your role, informing people about what this care moment is going to look like, explaining each step, and thanking the person for their participation. Very common nursing practice. And then SBAR, which is through the AHRQ, which really looks at handoffs, helping to explain what's the situation that's happening, providing the clinical background, providing what the assessment is, and then providing what the recommendations are, and making sure that the person receiving the recommendations can repeat back those steps and recommendations so that's clearly understood. These are really important tools that are available. There's many other frameworks that can be used that really strategize and systematize how do we do communication right for handoffs and transitions to reduce the likelihood of trauma for individuals with complex needs. Next slide. So just remember, we've got to focus on trauma-informed practices, the importance of cross-training and partnerships, like Mary and others said. Recognize that people are complex. We all are complex. We all have complex needs. We all come from our own backgrounds. We all have our own presentations. And you don't have to be labeled to be complex. We all are complex. So we just have to recognize that we have to meet people where they're at, maximize information, communication, and a sense of control for individuals in crisis who might not be able to cognitively process what's going on because they're so preoccupied by the crisis. And then, as always, supporting the staff trauma in all of this. So just some really important highlights for people to take home with them, to put some punctuation marks on all of this work that we're doing collaboratively and together. So thank you very much. That's the NASDDDS Minute, and keep going, Aisha. Turn it back to you.
Thank you so much, Deb. I cannot say enough about how much I use the NASDDDS resources and what a wealth of information that is. So thank you for always pulling together the research, the best practice, and situating us in the stories. So appreciate it. Next up, Dr. Matthew Goldman. Matt, I'll turn to you for Data Corner. Welcome.
Thanks. Good to see you, Aisha, and hi, everyone. So Data Corner, for those who are new to the jam or haven't seen this before, is our monthly highlight of various research, evidence-based, quality metrics, anything focusing on data. And so to kick us off in 2024, I wanted to revive the Crisis Jam Data Corner Journal Club, which basically looks at an article of interest. Given the focus on people with intellectual and developmental disabilities who are in crisis, and our keynote presentation and the feature presentation today, wanted to highlight this study by Luke Kolb, who's based at Johns Hopkins, and he's led a whole area of research focusing on mental health screening in young people with autism spectrum disorder. This article, which the link is going to go in the chat, highlights how young people with autism spectrum disorder are at increased risk for mental health crises, and acknowledges that early identification, prevention, and treatment could really improve child and family quality of life and also potentially reduce healthcare costs. And so what he's done is he's developed a screening tool called the Mental Health Crisis Assessment Scale Revised, the MCAS-R, which is a 23-item tool that parents report, and they use this tool in 406 young people with autism spectrum disorder. And what they found is that outpatient crisis screening is feasible, it's accurate, and it's well received by parents and clinicians. And so the next phase in this research is to actually implement this paired with a novel crisis prevention program for autistic children to really try to identify its impact in an implementation and intervention study. So just wanted to highlight how important research is for growing this evidence base in this area and in many other areas. On the next slide, just a couple other research related things to highlight. One is there's an upcoming National Institute of Mental Health workshop on advancing the science on peer support and suicide prevention. This is going to be a great workshop, and there's a couple of the work sessions that are focused on crisis services. And so encourage attendance there and sharing the link in the chat for that. And then also want to highlight that research funding from National Institute of Mental Health is still available under the Notice of Special Interest on priority research opportunities in crisis response services, which is basically a mechanism to enhance NIMH's focus on investing their research funds into health services studies that focus on crisis response. So just wanted to share those for this month. And if you have anything that you think would be good for Data Corner, please send them my way. Thanks so much.
Thank you so much, Matt. And the link's there in the chat and your email as well. So thanks for offering for people to send you suggestions. Last, but absolutely not least, Caitlin, I'll turn to you, and then Stephanie to do the legislative update. I think I can give you guys a solid 2 minutes, so get us there.
Great, thank you so much. So as most folks know, a lot of states have started their 2024 state legislative sessions. So Stephanie and myself from NAMI and Vibrant are hard at work tracking the 988 and mobile crisis related bills. A few to highlight that have been introduced so far in 2024. We've seen 2 fee bills from both Vermont and New York introduced. We also are tracking legislation in Ohio from last year that would allocate some cannabis funding towards 988. We're seeing some student ID bills, which would require that schools list 988 on their student identification cards in Maryland, Pennsylvania, and New York. We're also seeing New York introduce legislation related to 988 license plates, and which would generate some fee revenue. And I'll turn it over to Stephanie to talk a little bit about other bills in the crisis continuum.
Yeah, thanks so much, Caitlin. I will just point out that in the flurry of new bills, we've seen another early trend that seems to be emerging is an increased focus on funding and public policies impacting mobile crisis teams. So the someone to respond pillar. Just for a couple examples, in Utah and in Florida, there are bills pending that would increase funding for mobile crisis teams, increase the number of teams so there's better coverage. And also just another example of mobile crisis team policy, for instance, in Washington, there's a bill that would extend liability protections to mobile crisis team responders, similar to 911 first responders. And I think that kind of wraps up our update for this week, and we'll be back next month with more bills.
Thank you so much, Stephanie, Caitlin. Just really appreciate the work you do to keep us updated on the legislative changes on the state level. So really appreciate it. We've come to the end, but there's, as always, there's more next week. The next, excuse me, the next session will be a very second debate around mental health should not come in a police car. So it'll be a debate format between Sabrina Taylor and Dr. Jen Stuber. definitely turn into that. That's a fantastic way of getting different opinions and different sides of a really complex issue. This is the very second one of these. So just want to thank you for your time, and also encourage you to come in 2 weeks for the highlights of the ASAM criteria. Thank you everyone for being here. Again, Aisha Delaney Rumsey, Chief Strategic Growth Officer at Fountain House, and I'll see you next week in the audience. Have a good one.